This conference will now be recorded.
Okay. You know, we haven't done in a while. We haven't been here.
Hey, Ray.
Is that Tina?
Mikey was mad at the other Mike for taking a lunch break the last time we were here. He was back, he's in the back room eating the bar. Mikey's just like.
We haven't done a stereo in a while.
Oh.
Really?
True.
Y'all do scenario order
Interesting. Very interesting.
now?
Let me see your right.
Oh,
Let's say acid triple.
I won't say what it is.
ooh.
Not me personally, but I have one. I went on a call like that. It's a three-wheeler. Yeah. Ouch. Yeah. No helmet. Ouch. No.
I don't know.
But like, when you talk to me, all the things.
They got your treasure or something.
Yeah.
No,
And now he's stuck there.
He was just like, oh, this sucks. Oh, my God.
Oh.
Thank
Just
you.
drink from it.
We are gonna do, like one-on-one scenario. You just have to have in front of the class.
Shia.
No, I was the second one.
Oh, okay.
That was aggressive.
I was excited because you guys are watching somebody else suffer through it.
What if I call your name again? Frank.
He's not here.
Frank's online.
So Shia. No, I'm kidding. Marissa? Where's Marissa? She's here.
That's no
She went to the
She'll be right back.
Mariana.
Mariana. Oh, you're like 9 minutes dating.
Okay.
Oh, no, they're gonna do one at the beginning and then afterwards.
Yeah, we're gonna start pulling y'all at the, like, while we're practicing, like cahoots and stuff, we'll just start pulling y'all one by one. We're not gonna get through everybody today, but I want you guys to practice like one-on-one.
So, a couple of things before we start, since everybody's in here now. The thing going on next Friday will start at 6:30.
Yeah.
Yep.
Okay.
So,
Ouch.
and I imagine they meet up at the GBC building.
Well, I guess it depends on what you're doing.
They're your patients.
We're patient.
Oh, I don't know. I've never been a patient. I just always waited for the call.
What?
Like I've done it.
All right,
but
I'll
I've
get
never
back
been
with
like
you
a
about
patient.
where y'all supposed to go. Jamie told me that y'all had to be there at 6:30 and that she would give me more information. I was kind of hoping that the guy that was in the class would know.
I've never been a patient. I don't know what they did.
Freaking get
All I did was respond to it.
Slackers.
Jesus.
I'll fucking leave right now.
So I'll get that for y'all to just be prepared. 6:30 next Friday. Be in Elko. Also, it was brought up earlier, so I feel like I need to just touch on this. One of your last Saturday, probably your last Saturday in class, is going to be, or not one of those days of your last week is going to be your national registry test. So we will take that here. Last time they broke it up into like groups. So they had like, I want to say they brought like 12 little computers down. So what they do is they come down, they bring one of their proctors down, they bring 10, 12 computers, however many it is. You'll come in here, you can't have your phone, you can't have nothing. They will give you like a piece of paper to write on, and that's all you can have. So I'll get the final date for y'all real soon.
So
But just-
June 6th or June 20th.
Yeah, it'll be somewhere in, it should be somewhere in there. So just know when you come in that day, if you want to give your family a heads up and let them know if they need you for some life or death emergency, to call somebody around here. Yeah, or call 911. But the day that y'all come in here to take the test, you'll be completely radio silent for a couple hours, however long it takes you to take your test. And so they'll bring you in that morning. You'll sit down, you'll take the test. They'll probably ask for like volunteers for like people that are willing to take it a little bit later. And so we'll have a group that shows up at like 9 a.m. and then a group that shows up at like 12-ish. And so they'll just break it apart like that. And typically if everybody shows up around like the same time, as people like file out, they just bring the next set of people in. So they rotate them around. So that's how that'll go. I'll get you a like definitive date because we'll set it up through the state. And you'll come here to take the national registry, because otherwise, if you're not going to be here, you'll have to like reschedule it through Pearson and do it a completely different day somewhere other than here. I think Elko has a spot. Reno, and then honestly, the weirdest one that I know of is like Round Mountain has a place. I don't freaking know. But apparently you can take the test in Round Mountain at their library or something.
That's a random place.
Yeah.
It's really random. Those freaking Yee trucks bombing through the parking lot. All right, so. You ready?
Yeah, probably.
Yeah.
We're gonna go there?
Yeah.
We'll just verbalize them. We'll have them carry all the.
Actually, got me for it. What do you want? I'll carry whatever you want.
You got this.
Right, so
Calvin's your patient.
Calvin's your patient.
He's like, dang it.
So you are dispatched to oh, I see this guy. All right, you are dispatched to a 28-year-old man. 28, you'll be 28-year-old male, that fell and is breathing. So your dispatch. It's breathing what? Funny. Okay.
I'm seeing it safe.
You're seeing it safe. Okay.
All right, go in. I gotta grab my paper now.
Martha, do you get the papers?
I go in, my general impression, that my patient is on the floor.
He's sitting in a chair just like you.
He's sitting in a chair. He's mumbling, he's breathing funny. How many patients do I have?
This one.
Just one patient. Okay, I'm gonna go in. I'm going to do my primary assessment.
Okay.
I'm gonna talk to the patient, make sure he's on alert.
Okay. This is as he appears whenever you walk in.
I'm going to stabilize the sign just in case it doesn't fell. And then I'm going to assess the airways. Okay. His breathing, how is it?
Okay, he's breathing.
What do I hear when I listen to it?
You have clear lung sounds. He is also like he's just normally to himself, but you don't notice any like obstruction.
Okay.
He's breathing at a normal rate.
Okay. I'm going to check his pulse.
He's a little tachycardic, but you can feel it good that he's ready to say it's like money.
I'm gonna go through and do full body assessment.
Okay.
Is there anybody with him?
Yeah, his friend's here. She said she walked in. I walked into his kitchen and his dog, he's laying on the ground, so I figured his dog was in there.
How did he get into the chair? Did he get up? Did he walk?
I kind of like drug him over here. He was able to like put weight on his leg.
Was he unconscious at all?
He was just kind of like laying there mumbling.
Okay. Does he take any medications or anything?
No, of course.
Yeah, he's takes something like they said it was a blood thinner for like a weird heart fever.
Okay. And do you have any allergies to anything?
I'm allergic to penicillin, codeine.
And what, are you having any symptoms? Is it getting hurt?
I've had person touch my neck.
Okay. When you fell, do you remember falling? Did you get conscious at all?
Never thought. Flash, people, stuff, chair. I'm not quite sure.
When you came in, did you find him unconscious? Or no? Was he-
No, he was laying there mumbling.
Okay.
I kept saying something like Casper or something.
Okay, so now I'm going to get vitals. What are your vitals?
So blood pressure is gonna be 180 over 100. His heart rate is like a little tachycardia, so it's like 116. Is this good to put it at 92% on there?
So then I will go ahead and administer oxygen because he's at 92. Okay.
How many
is a
is it?
cannula? Okay. 2 liters. And then, huh?
You were like one step before me, every question I was gonna ask.
Sorry.
No, you're not even sorry.
2 liters. And then I also want to get a blood glucose.
Okay, his glucose is 87.
And do you remember when the last time you ate was?
Some chips or something this morning.
That's what your text from you? Okay. The pain that you're having now, were you having any of that pain prior to falling?
No, headaches pretty, kind of feels like something dropped the bomb. The rest of the thing.
You don't need nausea or anything?
I don't even, the world.
Okay. Does anything make your pain feel better?
Pretty much in 6.
Oh, I forgot that. I need to get ALS too.
Okay.
How far is ALS? How far is the closest hospital?
We'll say our closest hospital is 30 minutes.
So So I'm gonna get him, since he's had a pain in his neck, his head, he's dizzy. I'm gonna get him loaded and start heading to the nearest hospital. And as I'm in the ambulance, I'm gonna do my secondary assessment. I'm gonna check his skin, how's the skin go?
It feels pretty great.
Warm and dry. His pulse was good. Okay, so then I'm gonna go do decap, check for deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, lacerations, and swelling. If I find any stuff.
You notice that he has tenderness and like fogginess to the back of his head. You know, we feel like a knot. You see the hematoma. It's pretty squishy back there.
Okay,
Let's see. Other than that, he has neck and back tenderness, and that's
when I go through in terms of his arms or his legs, anything like that. Okay. Do I find any bruising anywhere else?
no, there's that.
Like behind his ears?
No, it's like
Or just in the back? Okay. No blood anywhere?
no.
Any fluid coming out of his ears or anything? So I'm gonna get him loaded, and then I'm gonna head to the hospital, meet ALS on my way, and then check his vitals every 5.
Okay, how are you gonna? What position are you gonna
Okay. What's this?
Okay, all right. What is your differential diagnosis?
My one diagnosis is a possible concussion, but now it is about hematoma. I'm not sure what that
Okay. So he has a high blood pressure, right?
is. Hypertension.
Yeah, he's got hypertension. We don't know how he got on the floor, but he did hit his head. He's on blood thinners. So blood thinners is a big one. Right.
Oh, and he has.
And he has no more of that with it. So brain injury somehow. He's mumbling is not normal, right? It's altered. Yes. He's sitting there mumbling about it. Okay. What? Martha?
Martha.
Freaking Martha.
All the kids.
Yeah. So big head injury thing, right? So, if you're worried about head injury, what's another vital sign that you can get that we were talking about a little bit last night about like, that you can kind of fix if you have to start reading for him or working for him?
Entitled.
Was it?
So,
CO2.
okay, that's good. So CO2, where do we want it? We don't want to hyperventilate, right? But where do we kind of want to aim for CO2?
In a head injury, 30 to 35, but normally 35 to 40.
Yeah, so why?
He's already in the normal, right? So you don't want to go too high.
Right, so that higher CO2 causes this, can like assist with that swelling in the brain. So as you bring the CO2 down, you're trying to get that swelling down in the brain. Yeah, so aim towards the lower end of normal. Don't sit there and hyperventilate. Or they used to teach that you just hyperventilated head patients. Don't do that now. Just stay on the lower end.
So since he was at 92, should I have just left the oxygen off?
You can leave the oxygen on. So the big thing, like, if you want to aim like 95 to 99%. So remember, it can't read higher than 100. There's a chance you're going to more than 100% in their system. Whereas more oxygen, like in a stroke or a CPA, like a stroke or a MI, you can cause more damage by giving them too much oxygen in that situation. So you want to aim for like 95 to 99. So you're not wrong for what you want to do.
Okay.
So the big thing with head injuries too, I was going to talk about it last night, is if you have somebody that you're suspecting is getting like pressure up in their head, if you keep their head neutral in line and with a C-collar, that can actually help, because if their head's kind of like tilted to the side, you want their blood and stuff to drain down. So a lot of people put C-collars on just to keep their head like in the upright so you don't get any excess pressure if you're going to kick off like a jugular. Want to help it like drain out. Also another thing, supine, the big thing with head injury, you kind of want to tilt their head up a little
just a little bit.
Yeah.
Okay,
So keep them at like a 30-degree angle.
okay.
So keep their head elevated just to help with that extra pressure in their head. It's gonna help it all right now. Whether that actually helps or not, we're gonna do what we can, right? So, good. Wrap it
Did I
up.
even miss anything?
So, circulation. So you hit airway and breathing. You hit his pulse, but you didn't do your skin signs till later.
Oh,
So-
okay, when I did my secondary assessment, I done that first.
Yeah. So your general impression, right, and then your abscess or chief complaint, and then your airway circulation.
Okay,
So, and then move down to your history taking, which you did a good job, like asking the history there, but then your secondary assessment.
So on the history, you mentioned, or he mentioned that he was allergic to the flu vaccine. Is it still true that they could possibly be allergic to like dairy and eggs and stuff like that?
I think a lot of like the vaccine allergies are from like eggs and dairies. What I've heard, I haven't heard anything different, so that'd be a good question for Calvin, because he's in nursing school right now. But I have heard that it's like a big eggs, dairy thing that makes you allergic.
So when they say that they're allergic to the flu vaccine, when you start asking, hey, are you allergic to eggs or?
Yeah,
you know,
absolutely.
Did you happen to eat eggs and that made you pass out or something like that?
Yeah.
Okay.
Absolutely. Another one is like another medicine that you can give is like an A or paramedics. It's important to know if they have like a shellfish or an tree nut allergy, because like ipratropium, like Duonex, a lot of times not the actual medication, but what they're suspended in is a derivative of like tree nuts or shellfish. So you have to be careful, like asking those kinds of things. It's always good information to have. So absolutely.
So was that like the neurogenic shock?
Yeah, so his blood pressure was high, even though his heart rate hadn't gone down yet. So don't, like, if they don't have those three things, don't be like, oh, they're not in, like, they don't have a brain injury, right? So that's like a bad brain injury, whenever they start to get that Cushing's triad. So with the hypertension like he had, even though his heart rate wasn't low, he was still having some kind of brain injury. Which, what can you do for that? Drive 3%. Yeah. Y'all can't, we can't right now, we will eventually, but yes, 3%.
So then you also want to get a 12-week?
Yeah.
Because his breathing sounds.
Yeah, so any kind of altered mental status. So the big ones, why you would indicate to like get a 12 lead. So think altered mental status, that's a big one. If they're having any signs of a stroke, you always want to get a 12 lead, because if you have signs of a stroke and signs of a heart attack at the same time, it is what until proven otherwise. I think y'all been over this. So it's an aortic dissection until proven otherwise. So if you have any kind of chest pain with stroke symptoms, any kind of like EKG changes that would tell you that it's a STEMI or heart attack. Like if you send it off and they're like, oh yeah, that's a STEMI, and they're having stroke symptoms, it's an aortic dissection until proven otherwise. So altered mental status, stroke, obviously all your chest pains, any kind of abdominal pain from like the belly button up gets a 12 lead. Any kind of syncope or near syncope always gets a 12 lead. So those are the big ones that are like always get a 12 lead on these patients. So with him having altered mental status, absolutely, like that could always be a thing too. So it's good. Any other questions?
When you're transporting, try to keep them warm.
Oh yeah,
Without
try
them?
and keep them warm.
Like
Yeah.
blankets
Did you
and
say
stuff?
that? No. Okay, yeah, so treat for shock. Yep. So you're gonna try and keep them warm for sure. So even though you're not laying him supine because he has a head injury, you're gonna tilt his head up to that 30 degrees, keep him warm. Oxygen.
On the secondary assessment, when you get to that part, can you name out all of the body systems that you're checking?
Yeah, so whenever you're doing like a trauma assessment, especially like in our skill stations, as you're going through it, tell me why you're looking at what you're looking at. So if I'm gonna start at his head, I'm like, okay, I'm gonna palpate, I'm gonna look in his ears for drainage, that tells me that it could be CSF, right? I'm gonna look for vital signs, that tells me he could have a basal or skull fracture. Just say that stuff, just so like whenever you're in real life and you're actually doing it, you know why you're looking for that. It's like stuck in your brain, it's gonna be muscle memory. Right, so I'm gonna look for tracheal deviation. That could be a sign of a tension pneumothorax, right? Even though it's a late sign, we still know what we're looking for and why we're looking for it. Does that make sense?
Mhm.
Okay, clear as butter. I like it. Good. Y'all have any input?
Calvin, has there been any change to the flu vaccine and egg allergy?
As far as I know.
All right, who's ready to get through all of 11 slides?
Yeah.
Let's do it.
Let's do it. All right, multi-system trauma, what does that mean?
More than one.
Multiple systems affected in trauma.
Trauma of 2 or more.
All right, you guys just did objective number 1. Good job. Learn how to manage the multi-system trauma patient, and then learn criteria on how to identify high priority patients. So we've talked about that a little bit. Does anybody recall like criteria, what would make someone a higher priority than another? Like just
Mental
name
status?
criteria. Okay, altered mental status.
Burn.
Burns, depending on what kind of burns.
Long
like
bone
what
fractures?
percentage. Burns with long burn or long bone fractures, that's definitely on there. What about pregnancy? How many weeks?
8.
I like it.
I try to do it.
22 to 24 weeks, depending on, usually it's that 22-week mark. So if they're like 12 weeks pregnant, they're a lower priority of trauma than a 22-weeker. Also, a lot of places that you work, it has to be a confirmed pregnancy by a hospital. So if they're like, yeah, I took a pregnancy test, I'm pregnant, that's a different priority than if they're like, yeah, I have a doctor set up, I've been like approved, we know I'm pregnant by a doctor. So a lot of times, depending on where you work, they won't do anything with them. They'll put them in the triage until they've confirmed their pregnancy, which sucks because a lot of people don't get prenatal care. So you'll go in, unless they're like clearly obviously pregnant, they won't put them at a higher priority. What about like mechanism of injury? Like think about like a car. What would you see on a car, not on the patient, that would make them a higher priority?
Spidering of the windshield.
Okay, so spidering the windshield is concerning, but it's actually not on that list. According to the CDC, it's not on that list that makes them a higher.
About the frame,
Yeah, so intrusion
Oh, yeah.
into the vehicle.
Is it 12 inches or more?
Yep, 12 inches. So into a passenger compartment. Now you can have where the hood of the car is crunched in and the passenger compartment has like no intrusion into it. That doesn't count. But if it's intruded.
Yeah.
Intruded. It's hooked into the
It has been
passenger.
intruded.
If it is into the passenger compartment, that's where it gets concerning. Good. All right, we'll talk about all that. All right, so what is multi-system? You guys already answered this. It has more than one serious injury. So more than one body system affected, right? So if you have 2 long bone fractures, that's significant, right? So that's 2. Are they bleeding out? That's like a bleeding problem as well. So teamwork, timing, and transport decision are key to proper management. I know that there's a lot of like test questions that'll be like, which one of these things is like, how is that worded? Let me think. It was like you're dealing with a multi-system trauma patient, being able to communicate with your partner falls into which one of these, and it's teamwork, right? So what about timing? What kind of timing are we aiming for in a bad trauma?
Is it a golden hour?
Yeah, it's a golden hour. Now, when does that golden hour start?
The time of the injury.
The time of the injury, right? Is it the time that EMS was called?
No.
No.
The time of injury.
Good. Very good. All right, so our critical decisions, this comes into play whenever you're dealing with like multiple transport decisions, right? So if you're dealing with multiple patients or if you have multiple facilities that you can take the patient to. So whenever we're talking about trauma hospitals, there's different criteria. There's like level 3, level 2, and level 1 trauma centers. So depending on what criteria your patient meets, if you have that option of, oh, do I need to take them to a level 3? Do I have to take them, could I take them to a level 2, or do they have to go to a level 1? Obviously out here, we don't have that luxury, right?
Does anybody know where the closest level 1 trauma center is?
Reno?
Utah. Oh, yeah. It's always hitting. The second closest one is Vegas.
What's Reno?
Reno is a level 2 trauma center.
So level 1 handles everything, burn,
Yeah.
all the
Level
above.
1, the only difference between a level 1 and level 2 trauma center is teaching capabilities and burn care. So that's really the only difference. So any sort of like multi-system trauma, outside of major burns, a level 2 trauma center should be able to handle. But what classifies him as a level 1 is the teaching capabilities and the major burn care. So as far as just like your day-to-day, like car wrecks and stuff like that, they should be able to handle that at a level 2 facility.
Now say I have a level 3 trauma, right, facility, that's 5 minutes from me. And this patient's blood pressure is 50 over nothing, their heart rate's 150, their arm's locked off. And I have a level 1 trauma center that's an hour away. Which one am I going to?
Level 1.
I'm gonna go to level 3 to get them stabilized. So they need blood, right? And they need possible other interventions that I can't do. Sometimes those doctors will go in and put stitches in like big bleeds. Now, if it's something that they just need that level 1 surgeon for, and they can like make it to that level 1 center, I'm gonna send them there first. But if they need to get stabilized, you need to send them to the closest hospital. So most EMS out here doesn't carry blood. If you're carrying blood and you have other stuff that you can do, that's where that might change. But just know, like if you're even taking a patient, if I was driving a patient from Elko to Reno and I was passing Battle Mountain and my patient crumbed and I'm like, they need blood now, I'm gonna pull in here because I need to get them stabilized and I don't have blood. So whenever you need to stabilize a patient, you want to get them to the closest, most appropriate facility to stabilize them, right? Would I want to go here? Probably not, but they have blood, so. All right, so here's our physiologic criteria. So what's going on with our patient that's going to determine severity. So if they have any kind of altered mental status, you said, right? Hypotension, the big one they harp on is a blood pressure. Systolic blood pressure less than 90 is more severe. And then abnormal respiratory rates, that makes them more severe. So any one of these things, if you keep adding on, the higher the priority gets. So anatomic criteria. So what kind of injury patterns are you seeing? So amputation, proximal to wrist or ankle. What does proximal mean?
Close to,
Okay, so proximal was distal.
further away.
Further away, good. So pelvic fractures, that's a big one. Because we can bleed a lot into our pelvis and not, you could have a patient that's bleeding in the pelvis and you don't even see it until it's too late. So our pelvis holds a lot of blood and it can hide a lot of blood. So don't be like, they don't have any bruising on their belly. They're not bleeding into their pelvis. Don't be that guy. Open or depressed skull fractures is a big one. Again, whenever you palpate a head, don't go poking your fingers into their holes. Use the flat part of your fingers to palpate. Any kind of paralysis at all. Penetrating injuries to central and extremities proximal to the elbow and knee. So pretty much here in, and then central, like all this is level 1. If I get shot in my ankle, you might think, oh crap, it's bad. That's the first gunshot I ran in Atlanta was a dude shot in the ankle. And I was freaking out. I hadn't run many gunshots before. And I was like, yeah, this is real bad. And I walked in there, I was like, man, it's the ankle, whatever. And then by the time I left Atlanta, I would see a GSW to the ankle. And I'm like, nah, it's an ankle, whatever. So it needs to be like here up or here in. So think of your big arteries, right? Let's see, chest wall, instability or deformity. That's a breathing problem. Tension, pneumos, that kind of puts them in this criteria as well. And then 2 or more proximal long bone fractures. So you think of the force it takes to just fracture one long bone in like a healthy adult or even kid. Now to give you 2 of them, that's significant injury to your patient. And then crushed, degloved, mangled, or pulseless extremity. So that includes tourniquet placement. Say they had a pulse, you put a tourniquet on and that's gone. The fact that you put on a tourniquet, that still brings up their priority. So does that make sense? Okay. Did everyone write that down? Sorry, y'all are still right.
So the big thing with any sort of trauma or multi-system trauma patients is early activation of resources. So on a good day when it's sunny and 75 outside, the wind's not blowing, and people do what they're supposed to, we can have a helicopter on the ground here in an hour. That's on a really good day. So what you got to understand is the golden hour that we talk about with trauma patients, that's not really a thing here. So we're just trying to get them where they need to go as quickly as possible, right? So even if you're at the mine and y'all have some sort of accident, somebody gets rolled over with a dozer, you have one of the vans out there turn over, start resources as quickly as you can, because it's going to take us 20 minutes to get there at least. And then, if we wait until we get there, now you got another hour. So now we're an hour and a half into this ordeal, and then they have an hour to an hour and a half flight. By the time they land, get the patient, do all the things, load them up, fly away, they have, an hour and a half flight to Reno, right? So now we're 3 hours into this ordeal. So early recognition of these things, it's better, like we've said 100 times, it's better to start it, cancel it, than need it and not have started it. So get them started early. And then if we get there and we're like, no, we're good. It's not our fuel. We don't pay for it. Y'all don't pay for it. Some mega corporation pays for it, and I don't care. So get them in the air, get them coming. If we don't need them, we'll wave them off.
And then I was hearing that we can't get the bird to come.
Well,
You guys
and,
have
that's weird, right? So if that's a thing, then that's a conversation. Yeah, that's a conversation that we all need to have with y'all's mine rescue team, because so there was an incident last year where a Mayday come out. Christian Estrada got the Mayday on his phone, and it took almost 10 minutes for all the dispatch systems to work through, and then us get paged out. And then we have a 20-minute ride out there, right? So now we're 30 minutes into this thing. You can have a helicopter almost over top of you in that time, right? So if y'all can't start it, then that's a conversation that we need to have with y'all's administration, because there's no reason why you shouldn't be. Does that make sense?
I think it was more of our dispatch call for a helicopter. We got told no, not for paramedics.
Yeah.
I think that's how that happened.
If y'all ever get told that by a flight service, the first thing y'all need to do is call Mike, or have y'all's call Mike or whoever, because that needs to be vetoed.
And that's what happened, is that they told us they wouldn't fly until paramedics said fly.
Yeah, no, there's no reason why that should ever be a thing. So if that ever presents itself as a problem again, then y'all need to run that to, what's his name? Eric.
Yeah, especially in trauma. Like, you guys see a bad trauma, you know it's a bad trauma. Like, okay, this guy's having chest pain. Will he need a helicopter? That's kind of like, something that we might have to decide later. But like a bad trauma, or someone gets pinched between equipment or anything, you guys know as soon as you lay eyes on that patient if they're going to need to get one. So,
yeah.
My opinion. All right, so we also need to look at what caused their injury. So sometimes our patients don't present as bad as like their car looks. So we talked about the intrusion, if it's greater than 12 inches, right, into the passenger compartment. If they were ejected at any point, that is obviously high risk. If they have a death in the same passenger compartment. So if you go on somebody and their passenger's dead and they're like, they don't look that bad, they're still a high level priority. And then I've never ever worked for a place that pulls vehicle telemetry data. But it's basically like, that airplanes have black boxes that give like telemetry data. Cars can do the same thing. I've never worked at a place where they're like, the telemetry data says it's really bad, so you need to go. Maybe you guys have different. I've never seen it pre-hospitally. I feel like by the time you pull that thing out and get the data off of it, we're already like off scene. So
The only time that stuff is used for is like insurance companies figuring out how fast you're going, right? There's a passenger, whether you read or not, something like that. It's not for us.
I was gonna say that should be out of our scope of practice.
right, yeah, I've never even. The only thing that I could say would kind of fit into this category is like iPhone alerts for wrecks. But even then, like I've had plenty of calls where it's like iPhone alert and like the car's not even there or like nothing's wrong. Like you brake too hard and that thing flies on the floor and it's like, crash alert. And then we get out there and find nothing. So I don't think I would even consider that. All right, special considerations. So older adults, again, their brains shrink as they get older, especially if they're like alcoholics, Alzheimer's, that kind of stuff. So older than 65, a lot of times that'll put them as a higher priority trauma. And they don't compensate for shock very well. So older folks, their bodies just, they don't work like they used to. So also a lot of our older population is on a lot of medications that can stop them from compensating for shock. What is a certain heart medication that's a big one that'll hide tachycardia? Beta blockers. Yeah, so metoprolol, anything ending in olol. So atenolol, sotalol, metoprolol, labetalol, those all cause the heart rate to stay lower. So that will hide a shock patient from you because you're looking, you're like, their vitals are semi-normal, their heart rate's fine. And you're expecting tachycardia because they just got their arm locked off, but now they're not tachycardic. That might be something you can ask them if they're with it.
Like these days, some of the beta blockers are being used for anti-anxiety medications, so it's not even generally the population anymore. You can run across like 22 to 13 kind of anxiety present the same way, so just be mindful.
Pediatrics is another one. So the big thing with kids is like they get put into the other seatbelts, the big kid seatbelts a little bit too quickly. And it can cause a lot of like abdominal trauma because where that seatbelt sits on the little kid, it can cause like spleen lax and stuff. So it's really important, like if a kid needs to be in a booster seat, they should still be in a booster seat. A lot of times parents are like, oh yeah, they don't need to be in a booster seat. They're big kids now, but they're really not. So that's a big one. Also kids have ginormous heads. So whenever they go down, they usually go head first. So that can cause a lot of like cervical spine damage. Remember your kids with Down syndrome or anybody with Down syndrome, their C1 and C2 are fragile anyway. So that kind of puts them at a higher susceptibility to like that kind of trauma. Anticoagulated. What are some anticoagulation meds? What did you say? I still didn't hear what you
Blood thinners.
Blood thinners, yeah. So what's the name of a blood thinner? Aspirin sometimes can be considered a blood thinner, sometimes not. So depending on where you work is whether they're going to count it or not. Most of the time they don't because it's not a true blood thinner. Warfarin, Coumadin,
Is it anything ending in in?
clopidogrel.
Okay, I was about to say like heparin. Is that
Yeah.
one?
Heparin is one here. But I don't see a lot of people taking.
So you won't really see people take like prescriptions of heparin. So what you might run into is like somebody that just went in for like a surgery. They might be like anticoagulated post-surgery and then they get in an accident on the way home or whatever.
Another one's like PICC lines. A lot of times if someone has like PICC lines in, they'll have heparin locks on them, so they'll have heparin technically. And then pregnancy greater than 20 weeks, usually it's 22 or 24, just depending on where you work is where they kind of set that deadline. Also,
This is so stupid too, because in Atlanta, I had a lady that like got cut off and she literally like ran over the curb. She didn't even knock her bumper off. She just kind of like busted the bottom of it and she got activated as a level trauma because she was pregnant. And I was like, listen, like it's really like she didn't even bust the tires on this car. And they're like, no, level trauma. And I'm like, yeah, all right.
Silly goofies. Look at where the seatbelt sits. Ask your patient if they're pregnant, where they set their seatbelt. So a lot of times people think it's more comfortable to set it on top of their belly or like across. Please don't do that. That's a bad thing. So it should be up like on their pelvis. Same thing with kids. You want it to be across their like pelvis, like lower down here. So nothing on the belly. They do make these fancy pregnancy seatbelts. I don't know the efficacy of them, so.
It's really bad.
Oh, really? Yeah,
I've heard. I don't know who told me.
I believe it because like this one, it wraps around her thigh.
What's it?
It's like they're getting open book.
Yeah, there's something about like an approval thing.
Not approved.
It's yeah, like, yeah.
Lift up the belly and.
Put it down. Yeah.
Like, drop it.
Right. Okay, so, determine roles beforehand, whether that's chatting with your partner on the way to the call, or if it is something like you trained beforehand, know who's going where. The thing about multi-system trauma patient, if you have one really bad, like multi-system, chances are this is like a car accident and there's more than one person involved. So this is where it's really important to talk with whoever's on scene, listen to whoever's been on scene before you, because they can give you a rundown, but also do your own assessments. We talked about this. Do your own
We have
assessments.
been burnt by this.
Yeah. So if someone walks up and they're like, oh yeah, they're fine. This guy has a bone sticking out of his leg, but this person actually had like an open femur fracture or like an open bone femur fracture or pelvis fracture. Like I've had that situation. Make sure that you're assessing people. So that's really important. And then usually how like we would do it, and you can figure out however you're going to do it with whoever you're working with. We would divide and conquer. So like we step out, he'd go one way, I'd go another, and then we'd convene, be like, this is what's going on with this guy, this is what's going on with this guy, okay, let's deal with this one first. So it's important to have that communication with your partner. Were you gonna, did I get you off?
No, I was just, same thing, I've had, the fire department be like, yes, this patient needs to go because their head freaking busted open. And I was like, all right, well, I'm gonna take this one, so I tossed him in the back of the truck, we're gonna find out the 12-year-old that was laying on the ground had a broken femur. Was actually the more important patient, not the lady who just needed stitches, right? So always do your own assessment of these people and walk around. You can listen, but walk around and actually lay eyes on everybody involved in this before you go to toss people in the back of your throat.
All right, so follow priorities determined by primary assessment. What's our first priority in a trauma patient? Circulation is good. We stop bleeding, right? So then what comes after?
Airway.
Yeah. So stop the bleeding if you can. Obviously, if they're bleeding out in their belly, we're not gonna put a tourniquet on their waist. The golden hours, big. Obviously, out here we're a little bit limited. Battle Mountain in general, so we're limited. But there will be a question about this and when it starts, whether it's on this test or a test eventually. It is whenever that patient gets injured. That is your golden hour.
It was on our it was on the practice test that I took for this chapter.
Was it?
Mhm.
I remember seeing it, so I know it's coming up. You got 1 hour to get that patient the treatment that they need. And it's not to the hospital, it is to surgery. So you can walk in the ER door, that timer is still going. It's until they get the surgery. All right, so general principles, obviously scene safety. We talk about this a little bit later, but whenever we're like parking the ambulance, if you can, so fire truck, okay, accident scene, if you can get ahead of people, that's ideal. So fire truck's a great traffic blocker. If they're gonna hit something, let them hit the fire truck. So make sure you know where you're parking. Make sure that you're looking for down power lines. So if there is a down power line, how many should we be? Huh? So it's one pole, yeah, so whatever's damaged and then another whole pole away. So you want to say 2 poles away from wherever it's down. So 50 feet is like if you have like leakage of the like stuff on the vehicle. How many times have I followed that? Probably not as much. But yeah, if there's fluids on the roadway because of cars, you want to stay 50 feet or park 50 feet away until it is secured. Your scene treatment, you want to do like the major treatments first, but then most of it should be done in the back of the ambulance. You want to try and limit your on-scene time for trauma patients to 10 minutes. Obviously, there's other factors at play there that you don't always have control of. If somebody's stuck in a car, it could take longer. If you are like trying to get them downstairs, that could take longer. If you're trying to like manage their airway and get their airway situated before you start moving them. Obviously, these things we don't have a lot of control of, but try to keep it within that 10 minutes.
Now that changes out here, yeah, because we're waiting on air resources most of the time. So on your test, if you ever see anything about scene times with like cardiac patients, stroke patients, or trauma patients, it's less than 10 minutes. Out here, you have some dynamic changes. Yeah, right, because like, do I care about getting off scene in 8 minutes when I got a helicopter, but they're not gonna be here for 45? Like, no, not really. So,
Again, like if you're, not out here, that's like their caveat, right? Because we do a lot of on-scene treatments out here. But whenever you guys, if you decide to go to like A school, IVs, that gets started in the back of a moving ambulance. You should be sitting on scene for 30 minutes trying to get a 22 gauge in the left pinky toe. So,
No shot.
we get started IVs with people's foot.
yeah.
I'd be like, please just put it in my bone. Leave my feet alone.
Yeah. Stabilized C-spine, so you want to make sure if they meet that nexus criteria or whatever criteria, and they need to get their C-spine stabilized, that should be right away. Airway management, we're treating for shock, restrict spinal motion, so if someone's unconscious, obviously that meets that nexus criteria. So don't go like jostling people. Again, most of the time the damage is already done. You're gonna hear that person that's been a medic for like 30, 40 years, and they're like, yeah, I moved the guy's head, I heard him pop, and he died. There's just no literature backing that up at all, unfortunately. So, what does it mean by life over limb?
You save their life.
You're gonna save their life.
Yeah. So if someone is in a burning car and someone's like, no, they're C-spine, I don't give a damn about their C-spine. They need to come out of the car. If I have the means to get them out right there, I'm not gonna stabilize C-spine, check their airway, blah, blah, blah. I'm gonna pull them out.
Pull them out.
Yeah, I'm just gonna pull them out.
Emergency move.
Emergency move, very good.
Frickin' grabbing, snatching.
Yeah. Yeah. Pediatric patients, and I'm also gonna throw in here like your like mentally disabled patients as well. I've ran plenty of car accidents where someone's like severely autistic and they just are standing there screaming because they don't know how to process everything that's going on. So that's your little thing here too. So pediatric, anybody that might be like a little bit further behind on the development stage. So emotional support, don't ignore the kids. If you can, just prioritize somebody to go comfort the kid. Like if you're dealing with parents and like there's an officer on scene or a firefighter, try to give them comfort too, right? So that's a big thing.
Also, just to touch on the pediatric thing, just because a kid isn't screaming at you doesn't mean they're not in pain. So pediatric patients, I have seen hundreds and hundreds of pediatric patients that will have like a broken bone and not be saying a word. I've seen grown men stub their toe and cry like 2-year-olds, and then have a 6-year-old with a broken arm that just sits there on the stretcher, right? So they actually did a study a handful of years ago, and pediatrics are the most underdiagnosed patients that we deal with when it comes to like pain management stuff. So just because they don't scream at you every time you touch them, don't mean they're in pain. So if they look like they should be in pain, treat them as if they are in pain, and don't just go to snatching on them and, be nice to them.
How many?
That's where like the full assessment comes in for the kids, because there's something wrong and it feels something wrong. Just because they're not screaming at you, we still need to.
Yeah.
Absolutely.
Yeah, like my best friend, her kid, she was babysitting a kiddo. Their kids are friends, but had a dislocated elbow for like 2 days. And he was just acting funny. And they were like trying to figure out what's going on. They're like, is he constipated? What's going on? And then they took him in and he had a freaking dislocated elbow. So, and he just was like whatever, acting a little weird, but wasn't like screaming and grabbing his elbow. So yeah, that's a big one. Who in here has been in a car accident? That shit hurts, right? Even if you aren't like seriously injured, you're still hurting. Like it's still painful. So keep that in mind whenever you're dealing with anybody in a car accident. Like you just got in an accident, of course it's going to be painful. Whether you don't have a bone sticking out of your leg or you do, like you're still going to be in pain. So keep that in mind. Obviously you guys can't do a lot for pain, but ice packs are a great thing, or calling for ALS. All right, so trauma scoring. it's where it gets a little confusing because they throw GCS in here. My initial thought when I hear trauma scoring is like just GCS. There's more that goes into that. So it can kind of describe severity or kind of give you a picture of how severe your patient is. So GCS is in there. And then they throw in the systolic blood pressure, respiratory rate, and then you get this revised trauma score. Don't worry about memorizing this. Like, it's good to know what it is and what you're looking for, but I wouldn't say to go and memorize all the numbers and how everybody gets one of those. Now, for GCS, that's a different thing. You should know how to calculate a GCS by the time you get out of this class. And if you want to learn this, cool. I'm not going to stop you. But the amount of times I've actually ever used this and don't have something that I can just like click and it calculates it for me is it's higher. I've never used it, so I don't know. They might ask like what it is or what you're looking for, but they're never going to be like calculate a revised trauma score of this patient. At least I've never seen that.
One of our test questions was.
Mhm.
Calculate this.
Yeah, one of our
It was
practice
11.
test questions.
Oh, okay. You probably won't have that on. I don't think. Is it on another test? Yeah.
No, that was just some crap in there, like homework.
Okay.
I was like, I'm not going through like homework.
Yeah. Yeah.
I already got to do it for the test.
Yeah. Okay, so people can be in more than one type of shock. Okay, so just because they're bleeding out doesn't mean that they might not have like a spinal injury. So you should, depending on the mechanism of injury and what you're seeing in your assessment, you should still be considering different types of shock. So like Calvin is our perfect example for this, right? He was shot in the belly. He had a low blood pressure. Shot in the belly. I'm like, oh, hemorrhagic shock. But was it a hemorrhagic shock? What kind of shock was he in?
Distributive.
Yeah.
He had a low blood pressure. He was tachycardic.
His lung was collapsed.
His lung was collapsed.
Oh,
Obstructive. So my brain, I'm like hemorrhagic. And then he's like, I can't exhale. And I was like, okay, obstructive. So make sure you're keeping that in mind.
I can't hear.
He's over there spelling it. You got your personal cheerleaders up here today. You're welcome. So pediatric patients, they don't compensate well. Do not wait for a pediatric patient's blood pressure to drop to be like, oh yeah, they're in shock. Do not do that. How do kids compensate the best? What vital sign is like ding, 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 shock? Heart rate. Yep. They'll get very tachycardic. And then once they start going into that irreversible, like decompensated, then their blood pressure drops, but their heart rate will also drop. So don't
And it
wait
is
for their,
fast.
it is fast.
It is, like, they go from, like, decompensated, or, decompensated to irreversible, like, quick. So recognizing that early is better, because they will crumple you real fast.
So the difference between peds and adults, so adults is that shock index, right, of the heart rate being greater than the systolic blood pressure. Same theory in kids. So what you do is you divide it. So it's systolic blood pressure divided by, it is heart rate divided by systolic blood pressure. For adults, it's 1. Is it? Heart rate divided, it's blood pressure divided by heart rate. Why can't I think of this? One of them.
It is your systolic blood pressure divided by
The heart rate. Okay, yeah, so systolic blood pressure divided by heart rate. If that's greater than.
I'm lost now.
So listen.
I gotta write it. Actually, I can write it.
Think of it as like, if your systolic is 120.
Yeah.
And your heart rate is also 120.
Yeah.
120 divided by 120 is what?
1.
1. Also, that's a positive shock index.
Yeah.
So realistically, the criteria is 0.9 or above.
Yeah.
So if you get something where your heart rate is now 140 and your systolic is 80, right now your positive shock index is going up.
Yeah,
Like more and more, right? Because
So-
80 can go into 140 more times.
This is what you're looking at, right? So
Pressure divided by heart rate.
heart rate divided by blood pressure.
Who lets me teach? That's what I want to know.
So, heart rate divided by blood pressure, right? So what you're looking at, because if your heart rate is greater than your blood pressure, then you have a shock index of greater than 1. So we're gonna make math easy real quick. For one.
So this is for adults. Hold on a second. So this is for adults. Now you got her on a roll. Yeah, now I got it.
So,
Yeah. So bifasicular blocks.
so you have a systolic blood pressure of 90 and a heart rate of 120, right? Somebody do the math.
You can use a calculator.
That'd be like 1.5.
Right?
Or less than that.
It's actually like 1.4.
It's still a lot.
It doesn't matter. 1.4, right? So what does that tell you?
Positive shock index.
So they have a positive shock index. And that's what we're looking at. So in the state of Georgia, when we had blood products, that was part of the criteria for our blood product administration was the shock index greater. So that's what you were looking for, right?
But here's the problem with kids, their heart rate normally sits higher than their systolic blood pressure, right?
Yeah.
Kids always have a higher heart rate, or they should. So whenever you're dealing with kids, rather than 0.9 or 1, the criteria is 1.7. So if they have a shock index greater than 1.7, that is shock for kids. So they take that higher heart rate into a little bit more consideration rather than the blood pressure more so. What are you kind of
190.
what kind of hieroglyphs have you got there?
Don't mind me. So is that a positive shock index?
Yes.
Yeah.
That's all you're looking at, right? Make it easier on yourself, right? Heart rate divided by systolic blood pressure gives you the number that you're looking for. In adults, it is 1 or greater than 0.9, right? And in pediatrics, it's greater than 1.7.
So that's where it differs. But still, whenever you guys are out in the field, I carry this personally. It's the heart rates and blood pressures for kids.
I also
because
carry one of those.
asking me to remember a normal heart rate for a 3-year-old, I'm like, no. So cognitive offload, get yourself a little cheat sheet. So whenever you're doing this, you can look and be like, that's tachycardic for a 3-year-old. Because you're going to see your first kiddo. I did this. I see my first 5-year-old and I was like, their blood pressure is so low, they're dying. But that was normal for them. So it's important to have something like this to refer back to, unless you're like the Rain Man and can memorize all of it. That's great for you. Yeah, I don't know.
Any questions about this? Heart rate divided by blood pressure.
One for adults, 2, 1.4 for kids, 1.7 for kids.
P 1.7.
And then adults get that universal shock too, right? Or that just-
There we
I
go.
have them written down. So, cheat sheet, that's great. That's the end of the slideshow. But another thing, that also has been very helpful for me is, because obviously I can't remember how to calculate a shock index. There is a app, it's called MD Calc. So I use that. I've told you guys about this before, but you can download it on your phone and then
Back.
Find a. It's gonna blow out.
Okay, so, you can do
Professionals,
this.
by the way.
I have this app on my phone, I have this star, so if I don't know it, then I can just.
Two.
Good,
Mhm.
clear?
Shock advised.
Yeah, so I use them for calc a lot, and, you can, there's a bunch of things on there, so, like your map,
GCS score.
yeah, your GCS is on there. 10-1, that there's a revised trauma score on, go to your, yeah. So.
Hey, that's what I used for my practice test.
There you go, yeah. So whenever you have it on the app, you can star these ones, and so you get to them easier if you're not certain. I use this app got me through medical school. Yeah, there's all sorts. Good, any questions?
Nope.
About multi-system trauma?
Not at this time.
Okay.
It's good. Now you have a few more days and we'll take y'all.
GCS.
All day long, I can finally have that one memorized, and then this is subdural, yeah.
Yeah.
So,
Yeah.
yeah.
B, A-N-D-N-A-S.
Is that Full House playing at the bottom right? Sorry. I'm pretty sure it was.
Okay, so, we're gonna do a couple of these, and then we're gonna open up the Kahoots, and I'm gonna pull y'all out one by one. So we can start doing some.
I'm drawing blank on the frickin' days. What is the blood glucose level, the abbreviation for it? Because I keep getting
BGL.
GCS mixed with
BGO.
BGL.
Sometimes you'll hear, what is it, CBG, capillary blood glucose, CBG. But usually BG.
Is there something similar, like, that's similar to GCS that we keep seeing?
GCR. Oh, yeah. Oh, my sternum just popped. That was incredible.
I don't think there's any other abbreviation. It's a G.
IBS? I don't know. All right, up and down.
Over there.
Cup of doom.
Couple.
Doom cup.
Where is my little, so you got it? There should be two of them.
Oh, wait.
Jessica.
Jessica.
What, again?
Right. Wait.
Which finding is worth 2 points?
2 points?
I opened spontaneously.
That's 4.
Okay. Lakin? Where's Lakin?
She ran away.
There's something out there.
Annie.
Yeah. What were we doing?
Yeah, which was
GCS.
2 points. We know it's not opens eye spontaneous.
Because that's 4.
Eyes and voice?
What?
Don't go eyes paint.
You're still on.
Flick.
Yep.
Yeah, I'm just trying to delete my little mark.
Okay.
Localize the pain.
Yeah. Do I need another?
Bone
Oh, really?
incomprehensible. What is localizes to pain?
Four.
That's motor, right? So
Yeah.
4.
Is it 4 or 5?
Four.
So
Four, but
localizes,
Is it?
no, it is 4.
Yeah.
It's 5
5, the withdrawals from pain
would be
is 4, localizes pain is 5.
Okay.
Does that mean that they can tell you where the pain is?
So localized, like if I do a pain response and they push my hand away, they go to the side of the pain and push it away, that's localizing.
Okay.
Now, that takes more brain power than pulling away from pain. So if someone like does that and they pull their hand away, that takes less brain power than localizing. Does that make sense? Allie. Okay, simple commands.
Simple command?
Oh, I heard a simple command. I'm deaf. Y'all gotta yell.
What?
What'd you say?
Chocolate.
Okay. Frank's Mariana. Not to be confused with Marissa. I did that earlier. I don't know why, like, I can look at you and be like, Mariana, Marissa, but if I read it, I'm like, Mariana.
Am I just giving you the numbers?
Yeah, so
Okay.
no eye opening. Yeah, so you'll give a number for each one.
Okay. This is 1.
Okay.
So verbal correctly states name, location, date, and why they are here.
That's the high.
Yeah.
For golf.
No, it's not for golf, it's.
Verbal is 5.
Okay, and then motor is no movement. That would be an odd patient. They're like laying there, they're like, I'm here.
My name is so-and-so from.
It's like that.
Like on this one, it says coups and babbles, is that for like the babies?
Yeah.
And pediatrics, okay.
Are you looking at AFGAR or DCS? Okay, yeah, it's still for me either way, but there's one for AFGAR too. We'll talk about
Oh,
that.
yeah. All right.
Okay, Jake.
Jake from State Farm.
What are you running, Jake?
So 2 for us. Verbal. 3.
So this
5.
one's weird because the way that they put these on, whenever you do a pain response, whenever they say externally, they're talking, like they'll localize what they're talking about, but whenever they say externally to pain, they're talking about this or like this. So they're moving their shoulder away, so that would be away like this.
So does that indicate like decorticate posturing?
I think so.
No.
Or Diceribet, yeah, sorry,
Diceribet, yeah,
Diceribet.
sorry. I think so because the way that this like website words that is odd.
So, does anybody disagree?
The verbal.
Okay.
I disagree with 5.
Okay. So let's start with the verbal.
Because it's just disoriented, he's not, so it'd be 4, right?
Because he's just confused, right? So the first one is confusion. And then the eyes do not open to pain,
So that'd be a 1.
right? So if they open to pain, then it's a 2, right? Because the eyes are
You
like
clicked the wrong
half
one.
And you still did it wrong.
You clicked the wrong one.
Frick. So your eyes are your aptitude score, right? So alert, verbal, pain, unresponsive. So, but yeah. Oh. Ah, who's next?
Steven.
Steven.
Eyes flutter after sternal rev. I was like a 3. You still responsive?
You said 3?
Yeah.
It's a 2.
Patient says only that hurts. What are the numbers? Is it 5? Or is it 4?
Let's talk to the hand.
His responses, I'd say like a 4. Saying that hurt, he's responding.
So you said 4?
Yeah. Limbs remain flaccid. 1.
All right. Anybody?
Eyes is gonna be 2 because it's just painful.
Wouldn't verbal be 3?
I think verbals, because he cries to me, where he's saying that it hurts.
Mix between. No, words out of my head right now. What was that one? It was a 3?
Yep.
Okay, cool. Because it's, localized.
So,
when they can-
just like you just said, remember eyes. Remember eyes is
Back off,
after,
lady.
right?
I got
So
the-
alert would be 4.
I got the thing.
Verbal would be 3. Pain is going to be 2, and since it's responding to that painful stimuli, that's why it's a 2. And then unresponsive is 1.
All right, so.
And it does, that's
oh,
for my
wait,
laundry when I get lunch.
Oh, disregard what I played. Don't worry about that.
I don't know, who is
I have the
next?
weeby dee dee dee.
It's you.
It's me. Well, unfortunately, it's the same as the first question. Moans incomprehensibly.
Weeby dee dee.
Sounds like you're stabbing a steak knife.
No eye opening? I'll take no eye opening for, 300. Wait for one of the other ones to pop up.
Okay, this one's kind of cheating.
It is.
Who's next?
Oh, sorry. I'm like, who's gonna answer?
I got the weeby dee
I
dee
want
dee.
Harlan.
BOP simple commands.
What?
Yep.
This conference